Hey folks, before we get to the show, Nick and I have a very exciting announcement for you guys. We are super excited to be presenting our Critical Care Time store and newsletter, which are now live.
That's right. You can subscribe to our newsletter to hear updates about the show. You can also go to our store and pick up some really cool Critical Care Time swag.
That's right, Nick. So guys, just head on over to the website. That's www.criticalcaretime.com, where you can navigate to the store or sign up for the mailing list.
And add yourself to the mailing list. Be sure to do both.
Of course, make sure to sign up for both. And on that note, with respect to the newsletter, we're going to have some brief synopses of shows that we've recently recorded. We're going to cherry pick some articles for you and have some comments for you guys to enjoy. And finally, anything we're into, any insights into this, that, or the other, we'll make sure to throw those into the newsletter as well.
So get excited. And now, back to the show.
Anticoagulation, though, is critical. And the best data of all is that anticoagulation decreases the risk of recurrence. And it's anticoagulation within the first 24 hours. That's the high risk period for when the clot is, quote, unstable and can grow. So you've got to get that patient anticoagulated 24 hours.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your host, Dr. Nick Mark.
And I'm your other host, Dr. Cyrus Askin. On this week's episode, we are going to revisit one of our favorite topics here on Critical Care Time, and that is pulmonary embolism. Specifically, we're going to focus on the interventions available to treat pulmonary emboli when anticoagulation alone isn't appropriate. And maybe systemic thrombolysis isn't the right answer either. Perhaps there are bleeding concerns, or perhaps it's just not the right patient. And so if you haven't had a chance to listen to our episodes on PE, please go back and check out episodes 15 and 16 from season 1 to help lay the foundation for our discussion today.
Right. We're going to build on what we did in season 1, and we're going to get much farther into the weeds and talk about some great edge cases and how to decide. Specifically, we'll talk about some of these challenging questions. When to use half-dose lytics or quarter-dose lytics? When to push for IR or OR management? In many cases, these are controversial questions in a field that's still maturing, and there's a limited number of high-quality trials to guide us. With that said, we thought this would be a really exciting, educational, and fun topic for a discussion with a guest. So we recruited a world expert in the universe of PE management, Dr. Rich Channick. Dr. Channick is an intensivist at UCLA, where he holds the Saul Brandman Endowed Chair in Pulmonary Arterial Hypertension. He's the co-director of the Pulmonary Vascular Disease Program. He's the director of the Acute and Chronic Thromboembolic Disease Program, and he's the director of the Advanced Pulmonary Vascular Disease Fellowship. Man, that was like a PFT I just passed reading that. Rich, thank you so much for joining us today.
Thanks, guys. Great to be here.
Awesome. So I think without further delay, we've got a ton to cover. Let's get to it. All right, Rich, we are thrilled to have you on board as we tackle some of these important and controversial questions in the world of PE management. But before we shift into gear, did you want to share with the audience a little bit about yourself and you know, maybe as Nick might say, what's your superhero origin story? Why did you decide to focus on pulmonary vascular disease and specifically pulmonary embolism?
Yeah, it's a great question. I'm one of those rare people that actually kind of always knew what I wanted to do. I counsel medical students and residents, you know, kind of find your passion. Obviously, a lot of people don't find it early. Even as a resident, I was really interested in pulmonary emboli and pulmonary vascular disease as a medical resident. And I actually chose my fellowship at UC San Diego because that was kind of the epicenter of thromboembolic disease back in the mid to late 80s. And so that's actually why I did my training there. So I got involved very early in this field of thromboembolic disease. I liked the physiology. I like the whole clinical picture and the challenges that it faced. And here I am, you know, well over 30 years later, still doing the same thing. So
that's fantastic.
Yeah.
I think, you know, maybe as we go, if you want to comment too, sort of on like how some of these things have changed, because I think that would be a fascinating perspective.
Yeah. I mean, one thing I would say just to say is that some of the controversies we're still having, we had in 1987. I really remember at the first ATS, American Thoracic Society meeting I ever went to in 88, there was a debate on how to treat basically intermediate risk PE. Do we give them thrombolytics? Do we not? And there was a very spirited debate in 1988, and we're still having that debate.
Yeah.
Excellent.
That sounds about right.
The pendulum swings back and forth. All right. Well, we don't want to rehash our entire discussion from the first two episodes we did about PE, but maybe just to set the stage, we should talk a little bit about kind of what is the landscape of risk stratification in PE, and kind of very broadly, like 30,000-foot view, what interventions do you broadly think of for each of those risk buckets?
Yeah, no, great question. So the first sort of rule of thumb is that the higher the risk the patient is, the more aggressive therapies we consider. And that's sort of a very broad statement. Most of the patients who have pulmonary emboli are what we call low risk, meaning that with anticoagulation alone, they're going to do fine, with very rare exception. At the very high risk, these are patients who are basically either actively kind of dying in shock on pressors, and they are, you have to do something, very, very quickly. The problem or the rub comes in the middle, that intermediate group. And those are the ones where we still debate. Do we get more aggressive with interventions, or do we just sort of sit tight with anticoagulation, which we know is going to be effective for the majority, but not all patients? Then it gets to, how do you stratify the risk? How do you know if somebody is in that intermediate risk and where they fall? And this is where there's been a lot of research and development. There's very simple ways to risk stratify, like if somebody has elevated biomarkers indicating, myocardial injury, like troponin, if the RV is enlarged compared to the LV. These are very simple parameters we can get very quickly, which help us risk stratify to some degree. But I think there's a lot that we could do still to make it more discriminating, because we still don't know, even if somebody's in intermediate risk, which of those patients, if you did nothing, is going to be fine the next morning, let's say, and which of those patients is going to deteriorate overnight, end up on pressors or worse, in which case you would have said, oh, I wish you had done something more aggressive, the night before, rather than just sort of wait. And we're still not quite there.
Yeah. Yeah, that's a great point. And I think that's kind of the crux of the discussion, is trying to come up with a more high fidelity way of, prognosticating which of these intermediate risk patients are going to fall more towards the lower risk element of the spectrum versus the higher risk element of the spectrum. And so I think, yeah, definitely one of the things we're trying to tease out a little bit more here on this episode. So with that kind of being said, you talked a little bit about risk stratification and some of the concepts there. I'm wondering, in maybe more granular terms, Rich, when you're approached with a PE patient in general, what are the tools that you reach for to risk stratify them more often than not? Are you looking at BOVA scores, PESI scores? Are you grabbing the ultrasound? Are you looking at the CT and looking for kind of the RV, LV, difference in terms of size? All of the above. How do you, there's so much data. How do you create a coherent picture of the patient?
Yeah, that's a perfect question. And the answer is somewhat all of the above. So just getting into it. So the European, there's some guidelines and some guidance on this. The European guidelines have suggested a fairly simple approach, that if you get a troponin, a RV to LV ratio, usually gotten by CT or echo, and we can talk about the differences in a second. And then if they have both of those things abnormal, we call that high intermediate risk. If they have either one, we call low intermediate. And there's some data that may dichotomize sort of outcomes to some degree. And then we still do use that. And the patient who, let's say, has a little elevated troponin, but the RV looks fine on an echo, and that can be done, as a point of care ultrasound. One of the challenges that physicians have is that, you can't get, an echo immediately, a formal echo. You got to wake up a cardiology fellow. They're not happy to come in. And so, we need, obviously, as people's comfort increases with doing their own echoes, point of care, that becomes less of an issue. And then at that point, we can do a little bit better to risk stratify. There are some, like you said, the BOVA score, which incorporates some other parameters. For instance, if a patient has a DVT, that probably increases their risk. Kind of makes sense, right? What's going to kill you is the next one, not the one that you have. And so if you have a nidus for another clot, that's probably a poor prognostic sign, and that may weigh us towards being a little bit more aggressive. Heart rate. And that's one of the messages we always give to critical care physicians, is that shock is not just defined by blood pressure. You can have a blood pressure of 110 and be in profound shock. Cold, clammy, organ dysfunction. Your heart rate's 130, your stroke volume's horrendous, but you're maintaining a blood pressure because of all the catecholamines floating around. And so we can't use these like hard cutoffs. So it becomes a more of a global, almost holistic approach to a patient that ranges anywhere from they look fine, no problem, go back to sleep, all the way up to this patient is dying. We need to do something like now. And whether that's extracorporeal support, thrombolysis, surgery, that's at the other end, but it's a spectrum. And so I always have a problem a little bit with these cutoffs, putting people into buckets, because that's not physiology. It's a spectrum. And that's where, the experience comes in to play.
And often somebody initially is in one bucket and then they move into another. They don't respect the bucket that you arbitrarily place them in.
Yes.
Can be buckets for sure.
Yeah. I wanted to ask, so, often there's kind of two stages to this, right? There's sort of the person who is seeing the patient, who diagnoses the PE, who needs to sort of decide what, how to risk stratify. And then there's kind of the expert one. And you've just sort of walked us through the expert, hearing the whole case, reviewing the chart, kind of, looking at the patient, what you do. But what about that first tier, which might be the ED doc at some outlying ED? What do you advocate for them to use?
I mean, they get a lot of ways it's similar. I mean, you do your initial, obviously initial assessment, and there's the so-called gestalt, where like how does he look? How does the patient look? And that's actually been shown to be pretty effective. In many cases, as much as our biomarkers, like this guy doesn't look right, doesn't look good.
Right. We're a no profanity podcast, so we'll just abbreviate that LLS.
Yeah.
Looks like.
yeah. I got you. Yeah, no, that's absolutely right. And you have to trust your clinical judgment, your gestalt. And so I think for the sort of frontline person, the first thing is obviously to not miss the diagnosis. And, what I always say is that I think it's the second or third most common cause of a malpractice lawsuit is a missed pulmonary embolism. I think it's second to like a missed fracture by a radiologist. And so you want to think about it when somebody comes in. And, most EDs are pretty low bar for getting a CT angiogram if anyone has pretty much any pulmonary complaint. And then, you do the basic stuff. You look at that CT, look at the heart size, the RV to LV ratio, what are your biomarkers, your troponin, your BMP, get your basic vital signs into a clinical assessment. And then you'll have gone a long way at stratifying that patient and deciding what you can offer that patient. One of the challenges I think we'll get into is not all hospitals have the availability of all these advanced treatments. So one of the things you're going to have to decide quickly is, do you consider a transition of care or transfer for that patient if you're at a smaller community-based hospital, let's say.
So Rich, before we start tackling some of those, two kind of questions that come up. One you alluded to is this like RV LV difference, CT versus echo. I don't want to lose sight of that because I think that's a really important point to make. And then a follow-up to that or related to that would be, a lot of times I get the call from the ER about a patient who, looks okay, but man, their PE is just huge. So like, how much stock should I or should I not put in their actual PE burden? How much does size really matter in this case, so to speak?
The first question about, well, actually, I'll answer the second question first, because that's a little bit easier. There really is no data or evidence that a larger or so-called saddle PE that's straddling the vessel branches just gives you a worse prognosis. And so what studies have shown pretty clearly is that larger clot burden doesn't correlate with worse outcomes and really doesn't go into the risk stratification systems that, we use. What does matter is how the RV is dealing with that clot burden. And I'm always amazed that you can see people, like you say, they have a big central clot. And you're like, boy, how is this patient like getting any blood flow to their lungs? But yet the heart looks fine, the patient's happy, they're, comfortable breathing, biomarkers are negative. And there's clearly, the beauty of the pulmonary vasculature is there's so much redundancy in thousands of vessels. So that second question is, the volume doesn't matter. Now, it may affect what we can do for the patient, because if someone has more peripheral clots, things like our thrombectomy catheters that we'll talk about may not get out there. And so we may have a different treatment algorithm for those patients. But in terms of prognosis, doesn't seem to matter. The RV-LV ratio, which has become a very critical part of the initial assessment of severity, really has a few little problems. So most of the time we're evaluating these patients, we just have the CT. We don't have an echo yet. And what's been shown, and actually the MGH group where I was up until 6 years ago, showed that there's not a great positive predictive value. There's a relatively high false positive rate for CT. So in other words, you do the CT and the RV-LV ratio is greater than 1, which is often a cutoff. You get the echo and the RV looks fine. And so that's kind of important because, if you might be overly aggressive, let's say, based on the CT, but the echo, when you get the echo, looks perfectly fine. And we see that not infrequently, and this publication from the MGH group showed that. And what they also did in a subsequent study, because the question is why? Why is there a difference? Well, very briefly, the problem with CT is that it's not gated based on the cardiac cycle. So you don't know whether you're measuring that ratio during systole, diastole, somewhere in between. So when they looked at the echoes, they actually found that the RV to LV ratio at end systole was greater than it was at end diastole. So there's a difference depending on where in the cycle you were measuring that ratio. And that may be one of the problems with the CT scan. Now, having said that, if everything else is pointing to like a really dysfunctional right ventricle, you can probably use that. But some of these borderline cases, I think it's a fine point that we should, have to take into account.
I think that's a key point for our listeners too, that it may overcall it, even though it's what's available, there's still a role for that echo. How do you feel about CT markers that might indicate RV function? So like, for example, if you see reflux of contrast into the IVC or the hepatic veins, what does that trigger alarm bells for you, Rich?
It does and it doesn't. I mean, I think I don't think, this is my own experience, I don't think it's that useful. I think there's false positives. I think you can get fooled that way. So I wouldn't necessarily use that as a decision-making finding.
Great. Okay. Well, now that we've introduced the topic, why don't we test the waters a little bit with a case? So suppose you are consulted by the ED about a previously healthy 38-year-old man who just got off a long flight, diagnosed with a PE in the ED. He's tachycardic to a heart rate of 110. He's got a blood pressure, which is 122/84, stable across multiple rechecks. He's on 3 liters of oxygen to maintain sats in the high 90s. On imaging, he has an occlusive thrombus in the right main PA with evidence of right heart strain based on the size of the RV to the LV on CT. He also has elevated biomarkers, both troponin and BNP. You go to see him. Handshake is firm, his skin is warm and dry, he's speaking in full sentences, he's comfortable, he's making jokes. Overall, he eyeballs really well. And I should add that you look at his chart, you ask him some questions, and he has no contraindications to anticoagulation. So how would you approach a patient like this in terms of disposition? Where in the hospital should he go? And what interventions should we be thinking about?
Yeah, that's a great case, and it's a fairly typical case that we see quite a bit of, maybe our most common case. And I can tell you that, this patient falls into, at least by standard criteria, into the sort of high intermediate, but, risk, which means that there's anywhere from a 10 to 25% chance that he could get worse over the next 24 to 48 hours. That's what the data would suggest. Although he's more likely than not to do well, there's more than a slight chance that he could get worse. And by that, I mean need pressors, have some evidence for deteriorating clinical status. And I can tell you, and I think we'll get into this, the whole concept of this pulmonary embolism response team that we developed and at Mass General when I was there in 2011 to provide multidisciplinary care for just these kind of patients where, there may be different ways to go, but we wanted to have a consensus team to discuss it, almost like a rapid response team for PE. And that was the whole concept of PERT that we started in 2011, which has kind of taken off. And so, and we can talk about that as a separate question, but this is exactly the kind of patient we would discuss. And their options are anticoagulation versus, let's say, a more aggressive therapy. I think most people would say that systemic thrombolysis should be reserved, given its risk, for patients who are more the higher risk spectrum. So this would be, would this patient go into we would go to a catheter procedure, catheter-directed thrombolysis or catheter-directed thrombectomy, or should we just watch them? What we found, and actually presented some of the data several years ago, was that the watch and wait approach is actually very reasonable for many of these high intermediate risk patients, provided that, you can watch them closely and that you have the option to pull the trigger on something more invasive like catheter-directed therapy. So this is a patient that we could go one of those two ways. Either we'd do an IR procedure now, or we'd put him in the ICU, and then answer to where they should be watched. We thought pretty strongly that these high intermediate cases, tachycardic, even though they look good, should be in a closely monitored setting. And I can tell you that some of what we would do for patients just depends on what time of day we were seeing these patients. And so, for instance, if this was a midnight case, what we found was that if you watch these patients overnight, a fair number of them will look much better by the morning. Heart rate will be down, biomarkers will be down, and you'll be like, well, we don't need to do anything more, anticoagulate. But some of them won't do that, and they'll still look kind of not that great. And, you get all up to move them in bed, and their heart rate goes up, they desaturate, and then we would take them. So what we found was that by that approach, it didn't really worsen outcomes. So even though the night calls, there was not surprisingly, a much bigger delay till they had a procedure, outcome wasn't negatively affected, giving us I think the lesson that you don't need to, for instance, call in a whole cath lab team at 1 a.m. for a patient like this, given all the parameters that you told me. But they have to be ready in the next day if the patient's not looking good to take that next approach. I probably would do that in this patient without seeing him, as I'd probably put him in ICU, anticoagulate him well, and then see how he looks in the morning.
I was going to just summarize, and you just summarized exactly there for me. Yeah, I think that's great. That's a great way to look at this patient and kind of think about where to put them and what to offer and how your plan evolves depending on what changes.
I was going to ask, based upon what you were just discussing there, kind of 2 points. One is you said anticoagulate well, specifically. And I wanted you to elaborate on what you meant by that. And then the other question I had was, we often talk about the risks of TPA. We quote data from this, that, and the other. But when you actually consider the risk of TPA in a patient like this, in a PE patient, how do you frame that, or what is your understanding, or what do you teach as far as that risk specifically?
Yeah, I mean, that's a good question. I mean, we know some about risk. I mean, obviously the thing the worst thing is the intracerebral hemorrhage, and most studies show in that 2% range overall, 2 to 3%
Right.
of intracerebral hemorrhage. We get to whether lower doses of TPA reduce our risk, and that's a little bit debated. I think to get to a lytic state, by definition, you're increasing bleeding risk. That's the only way the drug could work. And different doses get different patients to different degree of lytic states in terms of like reduction of fibrinogen. And there's a lot we don't know about systemic lysis, like what is the right dose to give. And so obviously a lot of the standard recommendations, 100 milligrams of TPA, for instance, which gives you that 2% bleeding risk. Obviously older patients, it's higher, and consistent data that, someone over 70 has a significantly higher rate of intracerebral bleeds than someone under 70. And so we have to take those into account. So I think that before we had access to thrombectomies and the catheters we'll talk about, it was a harder decision. But I think, there's such good emerging evidence on the catheter-directed therapies that, it's unusual for me to give systemic lytics to an intermediate risk patient at this point. Anticoagulation, though, is critical. And the best data of all is that anticoagulation decreases the risk of recurrence. And it's anticoagulation within the first 24 hours. That's the high risk period for when the clot is, quote, unstable and can grow. And so you've got to get that patient anticoagulated 24 hours. Low molecular weight heparin, for instance, has made it pretty easy because it's weight-based and pretty predictable at getting you to therapeutic levels. The one point I would make about that is that there's often a hesitation to give low molecular weight heparin if, quote, a patient might need a procedure. And that's, in my opinion, wrong. And for instance, at our center, we do all catheterectomy procedures, whatever, on full anticoagulation. So we'll use low molecular weight heparin almost all the time. There's obviously the rare cases, the patients with, recent surgery or neurosurgery patients, where we have to be super cautious. If you do use unfractionated heparin, and this is where my point came in, you got to make sure you get them heparinized. There's data that heparin drips get people anticoagulated less than 50% of the time at 24 hours. And if that's the case, then you're putting the patient at huge risk. So you better really make sure, if you're using a heparin drip, that patient is getting enough to be anticoagulated.
Excellent. Great points. Great points, Rich. I think that definitely helps me understand a little bit more about the risk of TPA when I'm talking to patients or talking to consultants about it. And then, of course, the approach to anticoagulation, which I think Nick and I are both fans of the low molecular weight heparin approach.
Once you get all your surgeons and proceduralists on board, like low molecular weight is clearly the way to go, I think. I completely agree.
Absolutely.
All right. It seems like, based on that discussion, that there are many cases where a patient who's on the fence, you'll kind of keep them close to the chest, watch them very carefully, and intervene when something moves the needle. I want to dig a little bit deeper into that, and I know we want to get to the discussion of the toys, what are the catheters, what are the pros, what are the cons. I definitely want to do that, but before we jump right into that element of the discussion, I want to know specifically what kinds of things, Rich, are moving the needle for you, and are there any cases that kind of delay that you mentioned, that watchful waiting, might come back to bite us in the rear, cases that we need to be tracking on at this point?
Yeah, no, that's a great question. And again, it's hard to put it into sort of sound bites, as you guys, are clinicians, intensivists know, there's a lot that goes into determining how sick this patient is. But I can give you just my own little sort of pearls. I mean, heart rate, I think, is critical. And that, as I alluded to earlier, I mean, if that patient remains tachycardic and it worsens when they move around, that's telling you something. Yeah, that could be just hypercatecholamines and they're anxious or maybe having pain. But short of that, I look for improvement in tachycardia over that period. And if they're still sitting there with a rapid heart rate the next morning, they're probably telling you something. And then there's obviously the little things like lactate and all the other things that you don't want to miss a patient who's in impending shock because their, quote, as I said, their blood pressure is okay. So if their lactate's a little high, trending that down, you want to see the troponins coming down, and you want to see the heart rate coming down. Those are things like are easily measurable. And if you're not seeing that, then, you probably need to go to the next step, or at least consider that. I think that what happened, one of the problems I've seen is that people may look fine when they're just lying still, but they, you get them up, getting them into a chair, getting moving a little bit, and suddenly they are not so good. And so it's not to say you get up someone and run around the hallway when they're in an interview, but you want to kind of get some sense with some activity what's going on.
I think that's great. I a number of times I've seen somebody who looked great overnight and then terrible with moving for breakfast or something. Even the subtle movement kind of reveals how tenuous their physiology was. So let's continue with this case. Let's take this case to the next step. So let's say pretty much exactly that. This 38-year-old with high intermediate risk PE spends the night in the ICU with a plan to maybe go to the cath lab in the morning. And then in the morning, he's persistently tachycardic. If anything, his heart rate's trended up a little bit. Maybe it's the 110s now. He looks a little bit worse, a little bit more tired. He's still on oxygen. You check a lactate and it's like 3 point something. It's not negative.
Right.
What would you advise for him? What would you recommend?
We would probably reconvene our PERT team on a multidisciplinary Zoom call that we do, and discuss it. Our interventional radiologists, my team, cardiologists would be on this call, and then we would, I can't say for sure, but I think this is the kind of case we would likely talk about either a catheter therapy, taking them down and doing catheter-directed therapy, or, and we'll get maybe this at the end, get them into a clinical trial. One of the really good things about this field is that we're finally seeing level 1 evidence being developed with randomized controlled trials, which we've never seen, with rare exception, in the catheter space with PE. And so that would probably be one of those two options we would take.
Excellent. All right. And maybe this is the opportunity now to talk about kind of what are those catheter options. Can you give us sort of a high level overview of what therapies can be offered?
Yeah. So there's two broad categories of catheter-based therapies. And I mean, you guys are, pretty young, but the catheter's been around way before you were, in terms of like going in there to say you could slice and dice a clot and aspirate it. But they've never really taken off until several years ago, within the last 10 years, where there are a couple companies that really developed dedicated systems for treating pulmonary emboli and actually got FDA approval for it. So the very first one, the first category is catheter-directed thrombolysis. So they're directly infusing a thrombolytic agent into the clot. The theory being that you could give lower dose, therefore decrease the risk, and still get the efficacy of delivering the stuff right into the clot. The device that got specifically approved was this ultrasound-enhanced thrombolysis, or so-called ECOS device, where you put in the catheter, they're very small catheters. You can put them in bilaterally. You turn on the ultrasound waves, which is theoretically supposed to disrupt the fibrin crosslinks, and then drip in the TPA. And a dose that's generally accepted to be about 12 milligrams, let's say, 6 per each side. So obviously much lower than the so-called 100 milligram protocol. So that's one way to go, is catheter-directed thrombolysis. The other big area is thrombectomy, thromboaspiration, where you go in and you suck the clot out or grab it and pull it out. And there's a few different FDA-approved devices. There's one made by a company called Inari, which is called a FlowTriever. There's another company called Penumbra that makes a device. There's a company called Thrombolex, which recently got a device approved. That's a little bit of a hybrid where you can actually drip in the TPA and pull out clot at the same time. So you have a few different options for thrombectomy or thromboaspiration.
Excellent. I think that's a great overview of the options that are available to us. And I know, Rich, as you've alluded to a couple times, and I think we'll touch on this again, you're not making this decision in a vacuum. This is a PERT team-driven decision where I would imagine, and correct me if I'm wrong, I would imagine when you're going down the road of intervention, you're leaning pretty heavily on the operators themselves to help decide which intervention is most appropriate for the patient. Is that reasonable?
Yeah, to some degree. I think certainly when it comes to like, you give them lytics of any dose versus just thrombectomy, that's sort of a group decision. Whether they use one catheter or the other, it depends on a few different factors. Not to get too technical, but when the Inari device is larger bore, the Penumbra device is a smaller bore in general, and so depending on the size of the clot and how far out it is, you may make that decision. The interesting thing is, and this is something I always talk about and what this team approach has led to, is I call regression to the mean. So the beauty of the team is that you have both non-interventionalists and interventionalists on the team. The non-interventional often come to it with a pretty conservative approach, like, we don't need to put a catheter in everybody. The interventionists come to it with a more aggressive approach, like, put a catheter in everybody. And what I found, to my surprise, I guess, is that the non-interventionalists, which I consider myself, got a little more aggressive when you sort of see some of the benefit. The interventionalists got a little less aggressive. And so you kind of met in the middle. And that's the beauty of group decision-making when it works, is that you meet in the middle and it's worked beautifully.
You alluded to this again, this idea of a benefit. I want to try, to the extent that we can with the data we have available to us now in 2024, I want to try to tease that out a little bit more, because most of the data that I'm familiar with, I mean, obviously, if the person is about to cross over into the high-risk PE category, but perhaps has a contraindication to systemic thrombolysis that you're worried about, yes, you're setting yourself up to save that person's life. I don't think that that's a terribly difficult concept to elucidate. But short of that, what are we really achieving other than brisk reversal in hemodynamics that may or may not be, at the end of the day, clinically relevant for that patient? Are we helping in regards to CTEPH, CTED? What are we achieving when we do decide to intervene, Rich?
Yeah, no, it's a nice question, and asked by a true skeptic, which is a good thing, because this is exactly the problem, of course, that does it improve outcomes, and what are the data? So we can dig into the data a little bit. And let's start at the sort of early stage. So there was something called a PYTHO study, which looked at systemic thrombolysis, full dose. This was tenecteplase. This was in Europe, and that was supposed to answer the question: with high intermediate risk PE, does thrombolysis improve outcomes? And their outcome was death or hemodynamic collapse of 7 days. They showed that there was about a 45% relative risk reduction in that endpoint in the patients who got thrombolysis with high intermediate risk PE. There was bleeding risk, of course, as well. But what I always say, and when I teach how you interpret data, is that the relative risk reduction doesn't matter. It's the absolute risk reduction. And when you look at it, the risk of that endpoint happening, death, and it was mainly hemodynamic worsening, was about 5.5% in the non-intervene group, just had anticoagulation. It was 2.5% in the group that got the lytic. So you were getting a lytic and improving by 3% the absolute risk of getting an event. So is that worth it? I don't know. The bleeding risk was about 2 to 3% of major bleeds. So that's not as impressive as 45% relative risk reduction. So
Right.
I always call relative risk reduction like a fool's gold, because you can use that to tout it, but 3%. So that didn't really answer the question. That was a 1,000-patient study. The only other randomized controlled trial that we have in this whole space to date was called the Ultima trial, and that would look at ultrasound-enhanced thrombolysis. That showed a significant reduction in the RB-LV ratio by giving low-dose TPA to a catheter. However, that was at 24 hours. When you looked at 90 days, there was no difference. So that didn't prove any improvement in later outcomes in that sense. And that was a 59-patient study total. That's it, guys. And so everything else is uncontrolled case series looking at these things. The critical question, though, is in addition to improving the short-term stuff, what does it do to long-term sequelae? Chronic dyspnea, chronic exercise intolerance, chronic thromboembolic disease, all the things you talked about. That's where the new studies are going to tell us. And we have at least 4 randomized controlled trials with catheter-directed therapies ongoing, trying to answer some of those questions. But we don't have those answers right now. I would just say one more thing, is that I don't think because we don't have those answers means we should never be using these devices. Because as you guys are in intensive care, this is critical care. If we had to prove outcome improvement for everything we did, there's not a heck of a lot we'd be doing in the ICU.
Yes,
The
yes.
majority of what we do, we know has physiologic effect and has maybe short-term clinical effect, but because of the heterogeneity and all that stuff, you can't necessarily prove long-term outcome. It doesn't mean we shouldn't do it, though.
And just to build on that, I think this is an especially hard situation to study because of crossover, right? The people who do worse in one group are often allowed to cross over to another intervention. So, I mean, that an intervention that we know works. So it's especially hard to prove benefit, I think.
That's true. And Rich, I think I'll throw back to the famous BMJ publication on the use of parachutes to prevent death and major trauma when jumping out of an aircraft, right? So I fully appreciate that response. You know, we don't have data for everything we do in the ICU, especially mortality data is very difficult to come across in the ICU. But I think you're right. I love toys just like everyone else, but I also think it's healthy for us to approach this stuff with a dose of skepticism to make sure we're doing right by our patients to the extent that we can, recognizing that the fog of war is thick.
Yeah, and I think I just not to belabor, but I think the dynamic nature of it, and I think one of you guys alluded to this, that things change over time. So we can't look at snapshots. And I think that that's the critical point that, and again, for a lot of the practitioners out there who will say, I don't have an interventionalist who can suck a clot out of somebody's pulmonary artery. What am I going to do? Are you telling me that, my patient's not getting good care? And, we want to avoid that. But I think, considering at least early transfer of these patients, so they're in a place at least where if stuff hits the fan, you say there's no obscenities in the show. So,
Stuff, indeed.
then you can be there, because this is a condition that once they're in the hospital, they should not die from. And it's a bold statement, but I think it's mostly true. If they've made it to the hospital, a patient should not die from pulmonary embolism.
I think that's a great rule. It may sometimes aspirational, but I think that's a great rule.
I mean, there are obviously situations like end-stage cancer where there are other goals of care, reasons why we might not do as aggressive care, and then the patient, may pass away from it. But other than that, you should be able to get those patients through.
Okay, Rich, so great discussion, I think, in regards to the timing and your approach, your thoughts, and sort of that brief review of the data. We didn't really get into this yet. I think we probably should. This idea of cardiopulmonary reserve. And so, this is a patient, he's in his late 30s, previously healthy, pretty fit individual. But how might your approach differ if you've got a patient who's, let's say, got COPD, they're on supplemental oxygen at baseline, they just have lower cardiopulmonary reserve. And maybe, let's say, they also have an extensive clot burden as well. How would you approach that differently?
Yeah, no, that's a great question. So I think it gets to the whole concept that, the next clot is what's going to be the problem, not the one that you have. So obviously, when you're faced with what they have, you're basing your treatment on all the things we talked about. Do they have signs of significant artery dysfunction? Do they, how tenuous are they? But the reserve basically means, what would happen if they got another clot? Are you going to be looking at a sudden cardiac arrest and profound shock that you may not be able to recover from? Or are you going to tolerate it? And that is based on, obviously the substrate you're dealing with. Is it a patient who has limited reserve that they couldn't tolerate even a little bit increased afterload to that right ventricle? I think the presence of DVT is important. And as I think I said at the beginning, that actually goes into some of these other scoring systems, because we do know that the presence of residual DVT does increase the risk to the patient. Maybe not surprisingly, versus the patient that the train left the station. There's no more clot in the leg. And therefore, if you just give them time to lyse that clot or dissolve that clot, for the body with anticoagulation, the patient should do well. So that does play a role. And those are cases, where we may consider filter, which we can talk about.
Excellent. Thank you.
Just to quickly kind of elaborate on that point you just made, Rich, do you recommend getting a duplex in all of these kind of intermediate high-risk patients to kind of determine how much clot, how much sort of Damocles is hanging over them?
Absolutely. Yeah, we push for that as quickly as possible when we see these cases.
Excellent. Awesome.
The other point, and I don't know if we're going to get into intracardiac thrombus or clot in transit.
Oh, we have a case.
Oh, it's on there. Don't you worry. Right. We'll get there. And so we will move on to another case. I just, last question I want to kind of ask when we're sort of debating interventions is, we have seen, kind of alluded to this a little bit in early in the show and in pre-recording, we have seen some more discussion in regards to, lower doses of TPA that one could opt for whatever reason. When do you use a lower dose of TPA? I don't know. When you feel like it, I guess. I mean, it's difficult to know based on the data that's available. But my question to you would be, when would you opt, let's say this person needs something, when would you opt for that catheter-directed intervention, which we know they have, bleeding risks associated with them too, particularly the Inari has, because of the size of the, I think in part because of the size of the insertion site, but versus like a trial of, let's say, a quarter dose of TPA and see how they do with that. How do you figure that out? Is that really just like a big PERT discussion or what?
It is. And it depends on, again, the availability of the procedural people and ability to do that, and this actually is a big issue at hospitals that don't have that, which are maybe a lot of your listeners. where the option of giving a low dose of TPA, the rationale, of course, is that, versus, let's say, the low dose through the catheter. It's like, well, all the blood flow goes through the lungs anyway, so why can't we just give it peripherally?
Right.
Well, milligrams, it's going to get to the lungs. And that's a fair argument. There's no real comparison. There is a trial going on called Pytho 3, which is going to look at just that question of half dose thrombolysis systemically, and the efficacy of that. So that's we're going to see some results from that. It's a pretty important study.
That's exciting.
But in practice, in the trenches, I would say, since we have our center has such an availability of the catheter therapies, the catheter aspiration therapies, it's pretty rare that we give systemic TPA even at low dose. Now, there's exceptions to that. We had a case actually not that long ago where, for a variety of reasons, the patient was too sick to go down for a catheter procedure. There's an older patient. They had widespread malignancy. It wasn't, a great situation at all, and they were in big trouble. We're like, well, let's just give them 50 of TPA and see what happens. So there are situations where we can do that.
Excellent. Nick, I think I've probably beaten this horse dead. You ready to move on to a new case?
Absolutely. So now let's say you have a 55-year-old woman with a history of non-small cell lung cancer with multiple brain mets. She's been receiving brain radiation, and then she presents with sudden hypoxemia. She's tachycardic up to 120. Her blood pressure is 90/55, which is lower than her baseline. She's tachypnic with a respiratory rate in the 30s. Her SATs are like 90 to 92% on 5 liters. You get some imaging, which shows a large saddle PE with evidence of RV strain. And just as you're on your way down to see the patient in the emergency department, you get a page from the emergency room PA telling you blood pressure is dropping, starting vasopressors. So in contrast to our prior discussion, how do you view this situation?
Yeah, so obviously this is one that's, going down quickly. Obviously the problem, the confounders are, you have what sounds like a metastatic malignancy. So obviously that portends, with brain mets, you're going to be talking about less than 6 months, probably survival, overall prognosis. So not a great situation, but, depending on obviously all the things like goals of care, et cetera, if you're going to try to save this patient, you're going to have to do something fairly quickly. And so this is one we would probably still hold a quick PERT call, and we would do that within 10 minutes. Your options for the patient who's really developing shock and what we might call high risk or massive PE are really 3 now, I would say, 4 actually. One would be push systemic TPA. Obviously, the patient has brain mets, so I would be pretty loath to do that. The risk of converting to bleed is very high. You could get the patient onto ECMO or cannulate them if you're in a center like I am and you guys where you have easy access to that. Problem there, of course, is you have a patient with stage 4 metastatic malignancy. So if you didn't give me that part of it, that's a patient we probably would be calling the ECMO team for. And we have the ability to get people on very, very quickly. And that's actually emerged as probably a real, almost a #1 treatment for massive PE. You could do surgical embolectomy, so whip them into the OR. Again, that still has a role, but a decreasing role, especially with the availability of getting patients onto ECMO quickly, VA ECMO. And then the 4th thing would be considering an emergency catheter thrombectomy. There's some data from actually the Inari device that even in patients who had high-risk PE, they had success. Again, uncontrolled data, so-called flash registry, I believe. And that, plenty of testimonials about patients who are really in shock on pressors, whip them into the cath lab, suck the clot out, everything gets better. Again, testimonials, individual cases. So those would be your 4 options for a patient like this. I guess the 5th option would be, goals of care, and obviously talk to the family that this is, maybe the end of the road here. So those are all the things we would consider.
Excellent. I think that's a great overview. And I threw in the part about cancer because I didn't want to make it such a clear-cut case.
Yeah.
And I love the sort of overview of the landscape of options there. maybe now is actually a great moment to talk about the role of ECMO, because this is something that we've also had an expanding use of ECMO in cases where there isn't maybe a contraindication to it. Do you want to talk a little bit more about that, kind of like when you reach for it, what that does physiologically, and how you can use that in the crashing PE patient?
Yeah. So, I mean, obviously, VA ECMO is advanced in its technology in the sense of easy to use, and teams that are dedicated to getting patients out quickly and cannulating them, and the way you can do it so you don't end up with ischemic extremities. Obviously, very simply, what it's doing is unloading the RV and delivering the blood, oxygenating the blood, and delivering it back systemically, and providing full, in some cases near full mechanical support for these patients who have, very little cardiac output intrinsically. It's been shown, and there are several case series of patients with massive PE doing very well in ECMO. We found it does is it actually allows you time to do definitive treatment. So once you're on, and this is maybe one of the best uses of ECMO, because as I'm sure you've all seen, one of the problems with ECMO is unless you're reversing the underlying condition, you may be stuck with a patient on ECMO, and that's not good. And so this is a very reversible condition. And so you get the patient on, and then you can decide, are we going to take him down for a thrombectomy? In some cases, would we operate on that patient? We would just give the clot time to resolve. So you got time to think about those things once they're on.
Are there specific interventions that you find play nicer with ECMO, or maybe ones that don't play nice with ECMO?
I mean, the concept of doing thrombolytics in a patient who's cannulated with large cannula makes people nervous. Not that it's never been done. I mean, I think the decision point is often this patient rolls in, basically dying, and in the ED, do they get the TP out and push it, or do they call the ECMO team?
Right.
And you can kind of go one way or the other. Sometimes you do both, like they push the TPA and then the patient's still crashing, and then you have to cannulate them. They don't like that, but it's been done, obviously, despite the very, very high bleeding risk. But that's the decision point. And we even have that. Obviously, hospitals that don't have ECMO, you only have one choice at that point, lysis. But we find that for the most part, what we've done is like either watch and wait or catheter thrombectomy aspiration in the patient who's on ECMO.
Excellent. All right. Well, I know Cyrus has another case. I want to ask you one more question about timing of lytics. And, if this turns out to be a stupid question, we'll just edit it out. So if the listeners are hearing this, it wasn't a stupid question. My question is, the half-life of TPA is reportedly like on the order of minutes, right? But I think people often have this idea that people are at increased bleeding risk for a really long time. And I think that comes from the fact that when people get lytics, we often observe them for 24 hours in case any bleeding that started during that short interval is ongoing and becomes clinically evident later, right? But, I guess my question for you is, how reluctant are you, like if somebody got lytics in an ED and then they're transferred and now it's like 5 hours later, what do you think their bleeding risk is if they get ECMO now? Because that lytics is presumably gone. It's been like 20 half-lives.
Yeah, you're absolutely right. I mean, there are exceptions to that. And, I like to check fibrinogen levels,
right,
as a reasonable surrogate for bleeding risk. And as they recover, let's say 150, 200 or so, then I feel much more reassured, unless there's something else going on, that the patient is, has a lower bleeding risk at that point.
So I say this because I don't want the person who's at the small community hospital who's watching a patient die in front of them to feel reluctant to give lytics if they feel like that's their only option to get them somewhere else, and just sort of this concept that it may not make something else off the table later. That's kind of a personalized decision based on other factors like fibrinogen, as you said.
Yeah, I would agree.
That's excellent. That's an excellent point. And that sort of pearl of checking fibrinogen levels is a nice one to keep in our back pockets, I think.
So I guess our listeners will get to hear this.
Yes, I think so. So just, again, be respectful of your time, Rich. There are a couple other kind of quick scenarios I wanted to run by you. And then I did want to take a last few moments to talk about the PERT team at your institution, and then maybe some of those clinical trials that you were alluding to earlier, just to maybe whet our collective appetite for what might be on the horizon. So before we get to that, though, like I said, another case. So let's say you're called by the medicine service, and this is regarding a patient who develops sudden onset tachypnea, tachycardia, chest pain. They've got increasing oxygen requirements. So they sound like they're getting pretty sick on you. You go up to the wards, you assess the patient, you bring along your ultrasound, and no sooner than you drop the probe on their chest do you identify clot in transit. You note what appears to be clot swirling around in the right atrium, and understandably, you feel compelled to do something. But I guess my question for you, Rich, is what should that something be?
So, I mean, you're obviously going to image their chest to see if there's, see what the PE burden is, or if there's PE, how much there is, because that may play some role in what you do. There is evidence that intracardiac thrombus or clot in transit in the right atrium, those patients do have a worse outcome than patients who don't have it. But, it's not something you need to get hysterical about immediately and rush them somewhere and run around with your hands waving. I mean, I think you have time to still work the patient up, do the usual things, risk stratify them, send them for, CT angiogram, because if they have, just a tiny little clot in one segmental vessel and they're causing some pleuritic pain and they have a clot floating around their heart, that's a little different than the patient has a big saddle PE and they got a clot floating around their heart.
Right.
So you want to put it in perspective of the whole patient.
Yeah, it makes sense.
Having said that, like you said, I mean, in some ways you could think about it that every PE was a clot in transit at some point, right? It went through the heart. Maybe you just happen to be catching it at that moment. So I think if you look at it that way, you can maybe look at it a little more perspective. But having said that, in general, when there's freely mobile clot in the right atrium, we'll generally want to do something about it, especially if there's a significant PE burden. What we can do about it, again, depends on where you are. There's aspiration systems that are really almost made for getting clot out of the heart. So they're larger bore, so they may not be so good at making the angles to get into PA, but they can go down and suck pretty much anything out of the heart. And there's something called an angiovac system and a couple others that we will use to remove intracardiac thrombus. There's some data with giving thrombolysis to fragment it, but we tend to go more with devices now for the intraatrial thrombus.
I think people have a strong psychological aversion to that. They feel like fragmenting it breaks it up and makes the problem worse.
Yeah, it doesn't seem to be the case, at least in studies that are, at least retrospective and case series, no randomized trials, obviously.
Very interesting. All right. And then I think, one topic that I don't really have a case for per se, but I just want to get your thoughts on is the role of the IBC filter. When is the IBC filter still a useful adjunct? When do you reach for it? What kind of patient benefits?
That's a good question. So yeah, I mean, filters are one of those things that people are so passionate, either one side or the other. It's a very polarizing thing.
Yeah.
Either the devil's work or they're life-saving.
Right.
And it's the pendulum has swung wildly, for somebody who's done this for many years, from, filters were put in everybody that, non-retrievable filters for most of my career, the Greenfield filter, it was there for life. And now, nobody wants to put in a filter. I think, the data, the studies are a little bit confusing because you have studies suggesting, that they have a higher risk of DVT when they have a filter in, but maybe lower risk of PE. But the patients that we consider filters in are, obviously people who can't be anticoagulated, contraindication anticoagulated, who have, quote, failed anticoagulation, so have recurrent PEs, or, and this is the gray area, patients where you feel they wouldn't tolerate another PE. So that's just that patient who has a big lead clot remaining, significant clot in the heart, in the lungs, poor reserve. So the next one's going to get them. But often we'll put a filter in that patient. But the point is, and a really important point, is that you got to remove these things as soon as you can, because the complications of filters probably relate more to how long they're in than the filter itself. And we have a whole system for making sure these filters get removed. That's part of our whole PE response team PE program, is that we keep track of who needs to get their filters out.
I remember reading once a study that the rate of retrieval with retrievable IVC filters was like in the single-digit % in some studies. So yeah, glad to hear that you've sort of figured out how to do it. As just a quick logistical point, it's a different service that puts in IVC filters typically, right? So it's typically IR as opposed to cardiology, or who are the proceduralists for this?
Yeah, that's a great question. So in our program, it's IR it does all of it.
I see. Okay. So that makes it like that lowers the barrier, I guess, to put in a filter.
It does indeed.
Nice. So I think, we're winding down now to the end of our time here with you, Rich, and very grateful for your expertise and your insights. I mean, I think this is coming together even better than I could have hoped for. So thank you again. You mentioned a couple of times now the PERT team that you have at your institution. You also mentioned some maybe clinical trials that could be available for PE patients, some of the more fringe type cases. Would you mind discussing those two kind of concepts a little bit for us so we can get some insight into PE response at your institution and what those patients might have available to them?
Yeah. So PE response team was something to develop. I grew up in Boston in 2011 or 12. Where we, saw that when patients came into the ED with PEs and when they were up in the hospital, that there was this mass confusion about who to call. Do I call IR, cardiology, pulmonary, hematology, surgery, and it was really tough because you didn't want to make the wrong decision. You didn't even know who to call, or you call everybody. So it was like the perfect disease where having a single stop shopping. You dial one phone number, you get someone on the phone that does the PERT consult and activates this team, and you do it rapidly. So within an hour, let's say you're doing a call. The funny thing was, actually, this was 2011, and I had this brilliant idea. Well, let's do like web teleconferencing to discuss these cases and show the X-rays. And when I would give talks about this, people would be like, God, that's like an unbelievably innovative idea. Like you're on the web teleconferencing. We use GoToMeeting.com then. Now, of course, pandemic and whatnot, Zoom is the standard of care. So it sounds a little less unique, but the ability to do that very quickly made all the sense in the world for a multidisciplinary disease like PE. And so when you look at the benefits of the PERT concept, there actually are some data that may shorten hospital stay, some signal of maybe reduction mortality, but I wouldn't put my life on that. But it definitely is the user satisfaction is dramatic. That the house officer, the ED guy, to be able to dial one number and get this team and get everybody involved, it's like gold to them. I mean, it's made life so much easier. So I think it's been sort of revolutionary that way. We have a consortium of PERT teams. We have meetings every year. I would invite any of your listeners. We have our next meeting, the annual meeting in September. It's every year in September. It's in Boston this year, the PERT consortium. The part of that, as you said, just in closing, is the knowledge about what clinical trials are available. And, like I say, there's four different trials going on and many of the hospitals around the country, are involved in these. There's the one with the Inari device, a randomized controlled trial. There's one with the Penumbra device, a randomized controlled trial. There's something called HiPytho, which is catheter rectal thrombolysis versus anticoagulation alone, a much larger study. And then there's actually an NIH-sponsored study called PE Tract, which actually is a agnostic type trial. Kind of cool. It's looking at any catheter therapy that one might use in your particular center versus anticoagulation alone. All really in the same kind of general patient population, that intermediate or high intermediate risk patient. So I think this is really critical that we generate this level 1 data So when we sit here, we can actually talk about a true RCT and what it showed and who might benefit from these therapies.
So let me conclude by asking you just one more question, Rich. So which questions do you think are going to be solved in the next few years, and which ones do you think we're still going to be debating in ATS in 30 years?
I think we will get an idea of the long-term benefit of these more novel therapies. We're gonna determine, do they actually decrease the likelihood of chronic sequelae of PE, or do they not? If they, regardless of that, we will get those answers. Probably what we won't get the answer is, who should we use them in? That sounds silly, because even if we showed no long-term benefit, these devices are probably still here to stay, and the therapies, and I think that's a good thing, because as you guys know, as critical care doctors, even if you don't prove something in a randomized controlled trial, within every large study, there's always a subgroup of patients who absolutely benefited from that therapy. The problem is trying to pull out that subgroup and apply it to your practice. And so even things that were neutral or negative trials, we still do every day in the ICU. And that's going to probably be the same for P. So I don't know that we'll get the answer to that. So we'll still be debating that to some degree.
Fantastic summary. I think that's the perfect point to leave it at. Thank you so much for your time and teaching us so much today, Rich.
Oh, my pleasure. Thanks, guys.
Is there anything you want us to plug for you? Website, something people can go to if they want to learn more about the work you're doing?
No, I mean, I would say that PERT Consortium.
Okay.
.org, I think, is the thing. It's yeah.
Excellent. All right. Well, thank you so much.
All right, folks. So this was really a great episode, I think, where we, of course, I'm biased, but a great episode, in my opinion, where we talked all things PE in terms of interventions, TPA, catheter-directed thrombolysis. We talked about ECMO. We talked about IR. I think we left no stone unturned. I'm very excited about what we were able to accomplish in a fairly short period of time. As always, if you want to learn more, you should check out the website where you'll find our show notes. That website's going to be www.criticalcaretime.com. While you're there, you can subscribe to our mailing list, or you can leave a comment.
And with that, we've come to the part of the show where we like to say thanks. First off, thanks to our incredible guest, Dr. Rich Channick, for sharing so generously his time and expertise. And also thanks to Dr. Gilad Jaffe, who was kind of behind the scenes here and was kind of acting as our off-air producer and was incredibly helpful in putting this together. Also, thanks to you, our listener, particularly those who have left us reviews, comments, or sent us emails. We read all of them. We really appreciate your kind words, suggestions, and of course, your 5-star reviews. We love hearing from you. So tweet at CritCareTime or individually at Nick M. Mark or at Askins_Razor. You can follow us on Instagram and Threads. We're critical_care_time over there. And then you should follow us on YouTube too. You can see us and hear us. So next, we'd like to say big thanks to C-Star Medical. We're fortunate and grateful that this episode, like all episodes of Season 2, are sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, www.cstarmedical.com, to learn more. That's SEASTAR medical.com. I'd also like to say a big thanks to the team that makes this possible. You heard about Dr. Jaffe behind the scenes, but we also have our team over at Podpaste to thank. They edit us and make us sound good. We also have to thank Kurt Belknap for the awesome theme music you're hearing right now. Disclaimers. So the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus those cases that we read were make-believe. They're purely coincidental. Finally, this podcast is for educational entertainment purposes only and should not be used in lieu of seeking medical advice. Call an actual PERT team. Don't listen to this podcast. On that note, I'm Dr. Nick Mark. See you next time.
And I'm Dr. Cyrus Askin. Wow, thanks, man.